case that we've been doing today, he has come to have a stenting of one of his vertebral arteries. He has a completely occluded left vertebral artery and he's a markedly stenosed right vertebral artery from which he's symptomatic. Because of the stenotic vertebral artery that he has, if he goes to extend his head and neck, that then becomes further narrowed and he becomes symptomatic from that. So in a lot of respects he presents several airway difficulties. So following an appropriate period of denitrogenation for him before induction of anaesthesia, he was cautiously given an intravenous induction of anaesthesia with an infusion of remifentanil at 0.4 micrograms per kilogram per minute, dropping down to 0.2 following insertion of his LMA, along with up to just a little under 1 milligram per kilogram of propofol, followed then by maintenance at around 0.7 mac of sevoflurane. So that formulated his maintenance throughout with volatile inhalational anaesthesia and intravenous narcotic with remifentanil. Those two together provide extremely stable anaesthesia for a procedure of this type. Because I wanted to avoid performing direct laryngoscopy for this gentleman, given that with his head and neck extension he actually exacerbates and causes symptoms from his vertebro-basilar insufficiency, because of the position one would ordinarily have to place someone in to perform direct laryngoscopy, for those reasons I chose for him an LMA Supreme in order to give me the confidence with second seal in terms of risk of regurgitation, that I could perform positive pressure ventilation for him for the duration of his 2-3 hour procedure perfectly satisfactorily. Because interventional neuroradiological cases have virtually no surgical stimulus in contrast to open surgery, their ongoing presence of an endotracheal tube and indeed the initial direct laryngoscopy in the first place are the two principal surgical stimuli, if you will, for the case. So when the interventional neuroradiologists are performing their procedures in what are essentially sub-millimeter resolution, they require road mapping, which enables them to use radiographic dye to take a picture of the patient's vasculature, then keep that road mapped image essentially as tracing paper over a real-time image. And because they need the patient to be in exactly the same place with sub-millimeter resolution, if I use a device which minimizes the risk of cough or movement during the procedure, it makes it a safer procedure for the patient to undergo, and it makes it a procedure which is less likely to require them to reset, to do further imaging while they're trying to work in these sub-millimeter resolutions. The procedure itself was extremely successful. The interventional neuroradiologists were very pleased with the deployment of the stent, and it showed very good revascularization essentially in that territory. There is no ongoing pain for the patient as a consequence of the procedure, so I'm able to avoid giving sedating narcotics to the patient before waking them up. So they're essentially being woken in what is effectively a drug-free environment as they emerge. Because of that, I need to have an airway device that minimizes any risk of their coughing. Again, this is another one of the reasons for my choice of the LMA Supreme as an airway device. Even in a patient like this with known airway difficulties, even in a patient like this with their obesity, I have the confidence in using a device like the LMA Supreme to provide my secure airway during the case, and above all to confer the benefits, especially for this gentleman, to avoid having to move his head and neck out of the neutral position. And at the very end of the procedure, it permits me to have him emerge quiescent, without coughing or straining, and without, in that sense, jeopardizing his femoral arterial puncture sites. His anticipated time of discharge would be within the next 24 to 36 hours.